السلام عليكم فيصل.
هلا وعليكم السلام.
أنا حسين العمري والتيم اللي موجود هنا. each of us will present himself. بعدين أنتم تقدموا أنفسكم طال عمرك ونبدأ بإذن الله. We'll start بالدكتور طيب.
السلام عليكم دكاترة، يعطيكم العافية. معكم الطيب القلاف الطيب يوسف من الكويت.
زياد غزال من الجامعة الأمريكية في بيروت.
محمد كردي الرياض.
عبد الله الخضير الرياض.
محمد الحجي من قطر.
يعني المالتي ناشونال تيم متجمعين خصيصا عشانك يا فيصل.
Thank you very much. It's my pleasure to be with you. And it's my pleasure to be with you and with all the panelists. And actually, I would like to present my team, Dr. Ibrahim, he is intervention consultant, and Dr. Ajaz, he is a senior consultant, and Mr. Rijaz, which is Ridul Bakar, and Julian, and Mr. Abbas, and medical technology from Madinah. And also we have anesthesia, and we will doing central sedation for our patient. And I would like to present the patient, which is
Faisal, can you fix your mic, please? We can't hear you very well. I think, can you fix the mic or remove your mask?
Remove. Okay, are you hearing me better?
يا سلام، أيوة كده. تفضل.
I would like to present a 70 years old chap who is admitted with the symptoms of severe aortic stenosis, and he had a history of syncopal attack or twice, 2 times, and NYH class it was 2 to 3, and he had also other comorbidity, which is diabetic type 2, and hypertension, and COPD, and bilateral osteoarthritis, which limited his mobility. And actually, we presented the patient in heart team meeting. The patient was approved by the surgeon, and also we have another committee which is called high committee for selecting the patients for high risk intervention, and presented, and also the surgeon they refused him, and we said that we will take him to the cath lab for cath. And as the patient lab was within normal, nothing to be significant to be mentioned. Next, please. And X-ray, as you're seeing that there is emphysematous chest, but it's moderate. And echo showed that aortic valve calcification with restrictive opening, and graded is 59, and area is 0.23, and has also on top of that he has mild to moderate aortic regurg. Ejection fraction is improved since 2 years with follow-up, but still ejection fraction is impaired. We have kinetic inferior and inferior lateral wall, and there is also mild to moderate mitral regurg. Next, please. This is showing that the function, which is about 45, and there is a thickening of both valve with calcification distribution in mitral and the aortic lifted. Next. Next. And this is the regurg, which is in both in mitral and aortic. Next. And this is the calcification on the lifted. But as you saw, there was no extension of the calcium or LVOT. Next. And if, as you're seeing, that there is symmetric hypertrophy, and actually was investigated for amyloid, and scintigram is done, and also LABA and CABA, and we found it's negative. So, as you know, the association between aortic stenosis and mild and amyloid, but there is nothing infiltration in this patient. Next. And this is the Doppler. Next. Next, as you see, other repairs. Next.
نشوف الليفت.
And we will leave you now with there is angiogram which is done. Next.
Can you play the angio? We can see it.
Yeah. Next. Let it work.
Unavailable.
As you see, the RCA, there is only mild proximal lesion, proximal to mid lesion. Next. Next. As you see, there is a proximal lesion in the LAD and also on the ostial of the LCX. However, it is confirmed by IFR that both lesions are not significant. Next. 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 Yeah. Here maybe carry up with the ostial disease of the LCH. However, it's not significant by IFR. Next, please.
I think, Faisal, what you are commenting on, we can see. We did not see any of the angio.
Yeah, you didn't saw the angio?
But we'll believe you.
Okay, good. Expected. Why is not appear? Don't appear? Okay. Okay, this is the picture. It's the important thing that the information received is that what is found, and as all the time we have technical problems, I wish that we will be better in the future. And no, now the CT scan, I think Dr. Al-Hadi will, he had it yesterday, and he will be go through the CT scan with you.
We'll learn from Dr. Al-Tayyib how to utilize and how to analyze CT scan. So if you give us a few minutes with Dr. Al-Tayyib, he will explain to us how to analyze the CT and how to choose the valve based on his analysis.
Excellent, thank you. Yes.
Technical, the mic.
The mic, guys. Okay, thank you. So basically, there are many softwares out there for CT analysis. I'm just going to highlight important things, and I'm sure majority of you guys know. This is 3Mensio. I've done a quick analysis at 30% phase, but as you see, there's a lot of motion artifacts around it. So when you're faced with these kind of scenarios, you try other phases. So I tried 20%, and it was also more of artifacts, so I went to 40%. Just curious, out of hands, how many of you guys use 20% as the main phase, or do you guys shuffle? Who used 20% for CT analysis? One. Okay. Who used 30%? Okay. 40? Okay. Split, I guess, between 30 and 40. So basically, for my own practice, I go through 20, 30, 40, and just try to pick up the biggest one of them. So this is, I chose here 40 because it's the least motion artifact. So what you're trying to do is you balance the coaxiality of the annulus, and then basically try to fix this in the middle, and then you pick on the nadir of the cusp, basically. This is the left cusp, and then you move into the right cusp here, and then you go into, sorry, this is the right, and this is basically the non-cusp here. So the quick general look here, as you can see, so there is a little bit of sinus here. So you probably try to go a little bit lower to exclude it. So you go a little bit here. So this is pretty much okay. I would just keep scrolling around to see if your sinuses would go below the line, but it doesn't. So this is good. So you would take this as your annulus, and basically you would just try to get on a quick look of the annulus, it's not calcified annulus. It's quite softish. There is not much of calcium to anchor the valve here. So on perimeter, it's almost 75. And on area, it's about 420. If you scroll, you go up to look for the sinuses. Basically, the sinuses here, basically, you go from the nadir to, or from the commissure to the other cusp. So here we have a general sinus. General sinus, I mean, it's 32 with this one. The left one is about 33. And then the one across from the nun, it's about 32. So almost all of them 32, 33. It's a generous sinus. And basically, you keep scrolling up until you meet the entrance of the left main. And the entrance of the left main here concerns me a little bit. So if I go to this view, basically, and take your explain to this, I want you to focus on this image here. Is it clear?
Yes, yes.
Look at the left main here. So if I scroll against it, there is a question about left main disease. Dr. Mohammed, would you rely on the CT for this, or would you?
In terms of left main ostium?
Yeah.
So it would be concerning for me that there is left main disease. And I believe the operators did coronary angiogram because of that, and it was okay in terms of left main assessment.
Okay, so that's one of the uses of the CT, basically to determine the proximal part of the vessels. So this is the left main height, basically. Where is the left main? This one. And then you go across to the right, and here is your right, basically. So that's the right. And then basically you go to check where is your STJ point, which is, roughly speaking here, there's some calcium nodule in it. And again, here, you would like to take the average, crossing the center, and a little bit here across the calcium nodule. So your STJ is about 29, and the height is about, what is the STJ height? Sensible height. Anyway, so it's about 25. I believe my colleagues are going to be using a self-expanding valve. And if we go here to the LVOT, the final thing is you check the LVOT. I usually do 3 measurements to 4 measurements. Every one is a 1 millimeter in depth, just to see. The things to look for is how big is this LVOT? Is it part of my planning to anchor in the LVOT? Is it funnel shaped? And the risk of embolization will be higher. It's almost looks straight tube from the, if you look here, looks like a straight line from the annulus. It's not like funnel shaped. So I think if we're using in this case self-expanding Medtronic, I would go probably with 29. Is that the?
So what's the what parameter did you get at the?
The parameter was 75. Was 75. Sorry, let me show it.
Dr. Tayyib, since we don't have a lot of calcium, would this affect your valve sizing?
Definitely, I would oversize. Like and that's the other thing. If you don't have much calcium in the annulus, you would think, okay, do I anchor in the LVOT or do I anchor at the annulus? And if I am anchoring in the annulus without presence of much calcium, I would be generous, going like 20% oversizing. The leaflet itself as well, if you notice, it's not really heavily calcified. The leaflet has some calcium, but it's not heavily calcified. So in cases like this, there are papers mainly done around patients with TAVI for native aortic valve regurgitation, NAVR. And the most commonly used in the registry forms was a self-expanding valve for these kind of scenarios. And the consensus was like to oversize aggressively, like 20, 25%.
One quick question that I want to raise for all of us. The gradient is 37, the mean gradient, so it's not super high. The EF is a little bit low, so that may be a low flow to some degree, and we will know this from the echo if we calculate the stroke volume index. If it's below 35, then it sort of goes with it. Because when you don't see that much calcification, you kind of have to think about this.
I think the DVI was 23, so it's a significant
Yes,
aortic
yes,
stenosis
that's a good
according
point,
to
yes.
the presentation. Ahmed, you have a question? Sorry to keep you waiting.
No, one comment maybe or two. First, looking at the left main and the RCA using the stretch view is not optimal. If you wanted to do it right, because you will have it either kinked or twisted or it look narrow. So you need to go to the bioblique view and get a shortcut and long cut to understand whether that there is serious stenosis or not. This is important. The second thing, the problem with this, you cannot extract the data from the AI and put it into the AS because it's the different disease. The aortic root is bigger than that. You cannot oversize the large frame valve. If you want to go with the short frame, you can do that.
The point is, it's about the anchoring mechanism in terms of abstracting the data. It's not the same disease exactly, I agree with you, but the AR, the NAVR cases, they usually are non-calcified annulus. And it's just about the technical anchoring mechanism, which helps here. I mean, if with AS, if everything, it should constrain it more. But of course, with less calcified leaflets, even opening this valve would not be a problem, like if you put a self-expanding without pre-dilatation. But just to go on the point of basically doing a coplanar, one trick with 3 Mensio, for those who use 3 Mensio, what you can do basically is you basically put a marker at this point, basically at the left main that you see here, and then basically you go to these ones. I have to check the series, basically. I don't have the series. And again, this is a more updated version than the one I have. احنا على قد حالنا بالكويت ناخذ old versions. But this is okay. You have to select the same series basically, which is in this case was 20%, and basically no, this is sorry 40%. This is 40%. So I have to go to 40% phase. I'm just showing you some tips and tricks about 3 Mensio basically, and you go to the marker, you best click on the marker, and there you have it in the short axis, and you save yourself some time basically here. And exactly as زميلي الدكتور قال, هذه هي left main, and here you can do a coaxial assessment to it. Now I can remove the marker, basically just delete the marker. And basically you can go on the short and long-term axis, and then basically here is you go on the short. So definitely it looks somehow tight. It definitely would worth doing a coronary angio and maybe consider even IVAS for it. But it's unfortunately, we could not have this cath images run to see how it looks.
Dr. Tayyib, based on the CT and the lack of calcification, which frame you will use, short or long? And why?
Honestly, both would work. It's I would say whatever you're more comfortable with, whatever you're preferring. The data, as I said, from registry and systematic reviews, the less calcification worked in both platforms, but it was most commonly used in self-expanding. I personally, again, how old is the patient? I can't remember.
71.
71. I personally, I would go with a balloon expanding because I'm trained more on it. It's not a preference of one or the other.
So maybe you believe in multi-level anchoring with the long frame.
Yeah, I prefer it as an initial one because if it fails, then it's easier to plant along in short than short in long.
Dr. Walid, كيف حالك? What do you think of functional testing with the severe aortic stenosis? How accurate it is? I think they did FFR or IFR and it was negative. Will you rely on that?
For physiological assessment, usually because you have the LVDP, it's going to be high, and it can't. The LVDP is going to be high in the context of severe aortic stenosis, which can impair your physiological assessment in aortic stenosis. Although, if it is negative, it's helpful. But if it's positive, it
You
won't
mean
be
if it's
accurate.
positive, you rely on it. If it's negative, then you question, isn't it?
Correct, because the elevated LVDP gonna make you.
Yeah. So would you go for another test, for example, since we are questioning the left main?
I would IVUS it.
You will IVUS it.
I definitely agree. I would IVUS this.
But anyway, you can leave it until they do the TAVI. Who agree? تفضل. يلا يا and I cannot see صراحة, we don't see. Faisal. We'll go back to you, Faisal.
حط الفالف.
Yeah, but anyhow, we will do angiogram after we completed our TAVI. So to confirming the things and showing that the easy accessibility to cannulate the coronary after implanting the TAVI, after implanting the valve. So actually, we started usually with groin, and usually we're doing ultrasound guided. And the puncture, usually we are doing with micropuncture, and then we be sure that 100% that we are in the right place. Most of the time, we are doing ProGlide and one ProGlide and AngioSeal. We found it's very effective. However, today we are putting a Manta, and we think that the results is good to accommodate it, and the result will be excellent with a Manta. And everything's done. I'm showing these, which the picture will be up here.
Well, I can't hear.
I think you mentioned.
Next, this is the pacemaker, of course, the pacemaker on the contralateral in the left side. And this is the micropuncture. And then that's it. Okay, next. So this is a cusp over lung, and as you saw that the pigtail, it is a non-cusp.
We're not looking at the proper. Are you looking at the floor? Yeah, no, that's better. Yeah. So we missed.
And here is
yeah.
the spot. Yeah, next. مش Yeah. Yeah. And this is a concrete wire. Usually we are using sapphire wire. However, this time we are using concrete wire. And we found everything was smoothly, nothing to mention. And just now we inserted the valve. And as you know that we are here putting the FX plus valve, which is new with all the features, the new features in this valve, making it more suitable for recanalization. As you know, there is in the multi-center trial, there's around 10% of unplanned BCI after TAVI, and more than half of them are presented with unexpected ACS. And actually, in the re-access study after PHP revealed about 7.7% unsuccessful cannulation of coronary. And as you know, it will affect the prognosis of the cases, and especially in the patients with ST elevation MI. As you know that from the things that all the information we're getting, we try to get a predictors or parameters that we can depend on them to be showing us the possibility of difficulty or we may face problem in recanalization of the coronary. And as you know, type of platform that we use and the relation between the THV and the coronary sinuses. And of course, the most important one, which we are concentrating, is the height of coronary thickness and depth of implantation. All of those parameters are affecting the canalization. Yes?
I think it's a technical issue.
Technical team, the sound coming from the other hospital is not clear. Can we do something about it? Thank you.
Faisal, can you please just explain to us how you will align the commissures and what's the difference between this valve and the previous one?
Yeah, there is actually, we have four steps doing a proper commercial alignment. The first one that it started with flush mode, and it should be on fluid drop, as you know, even from the FX before. And the second one, it will be on arm, which it will be in the, I will show it to you now. At this end, descending aorta, you are usually up, the hot marker should be towards the outer commissioner. And this is, after that, if we succeed in doing this, we passing or we pushing the valve toward the ascending aorta, and in that time, that for the alias and the up should be in the center. And after that, the fourth or the last one, after we deploy the preliminary deploy of the valve, we are seeing the dots.
Yalla, show us how you will do it.
So what
Live,
size
please.
what size valve are you using? 29.
Now, yeah, I don't know, are you seeing the up marker?
You mean the hat?
The hat marker, yes.
The dots.
Yeah, hat.
Yeah.
Yeah.
Hat. Okay.
No, hat mark.
Hat mark.
Yeah, it's an out of the picture.
Out of
Elio. Okay, it's clear now. Okay. And now, go.
Where was the port, Faisal?
Out of the picture.
Is that 3 o'clock?
Was it at 3, the port?
Now, the point, yes, it's 3 o'clock. Now, Sean?
What's your big thing? Yeah. Good.
Okay. The heart now is in the middle, as you say.
Which view you will use? The cusp overlap or the
Yeah.
coplanar?
Now we will do cusp overlap by cusp overlap. Okay. Now I will make the cinema like. Go back to the.
Do we have the hemodynamics?
So he's trying to reposition the pigtail catheter to look
Yeah.
at the.
Could we have the hemodynamics as well, please?
Yeah.
Good. Awesome.
Can we see the hemodynamics along with the screen, please?
Hemodynamic, please. As you see the heart mark now in the middle, right?
Yes.
Yes.
And I will check now with the restrictions.
Yeah.
Maybe okay.
Let's see. This is cusp overload.
What do you think? Okay?
Abdullah,
Probably push down a little bit.
you will start lower than that? Would you align the valve to the outer curvature of the aorta?
Yeah, to me, is this the areocaudal view?
What's your angle now?
This is areocaudal, Faisal?
Sorry, cusp overlap now.
Cusp overlap.
This is areocaudal?
Areocaudal.
Yeah. Dr. Faisal, the nose cone seems like stuck on something or it's more biased and there is significant AR, even at the hemodynamics, if you see the diastolic is quite low.
Can you centralize the valve?
Yeah,
Just rotate. Let's see.
or push in and pull back a little bit, just. There's
Yeah, if you push it and pull.
tension on
Okay.
the.
Muhammad, تفضل.
Yeah, I agree with you. You should, Faisal, you should push the wire and try to put there is a lot of tension on the prosthesis and the platform, and it's not perpendicular to the annulus.
Yes.
So you try to push the wire to use and try to make the valve prosthesis lies on the greater curvature. That will be more perpendicular, and it will be easy and you will release the stored tension. So try to go, this is a lot of tension in prosthesis. Go to the greater if you can by using the wire.
This is the best that I can.
Yeah, you should push the prosthesis.
Okay, now?
Push the wire.
Dr. Walid, what would you
Just
do?
relax the system.
Yeah, the other technique, you can go to the descending aorta and try to adjust, take out the torque. He might need to go to a 12 o'clock and then go back to the annulus.
I will start open, and if anything, I will recapture and do the thing that we do. But I think it will be okay.
Yeah. If you have an echo available in your lab right now, just take a look at the wire. Is this wire running under a cord or something? It looks like tensed against something.
No, they use the big tail to relocate the wire, so I believe
okay.
it's in the AV.
Okay, anyway, he's deploying now. Let's just give him time.
And you see the 3 markers in this new version of the valve at the bottom.
The valve will tilt
spacing now?
towards the greater curvature.
And the corner alignment is good with this view because the 2 dots are in the non-cusp.
Maybe you base at this point so that you stabilize the valve.
Oh, we will base in the last, usually.
Okay.
I think they lost the pacer though.
It will tilt
Recover.
this way. So on the greater.
Pressure.
Probably need to open more.
Okay. This is the last. With the pressure going up.
I think your pressure is
So you need to
yes.
open.
Pressure is low. It's deep.
That's very low. What do you think?
Very deep.
It's deep.
Go back to the picture.
Pressure is low as well, guys.
I think, Faisal, you have to recapture, realign your valve to the outer curvature,
Okay,
make it perpendicular to the annulus, and then you can deploy it. I think come out of the LV, let him perfuse for a while, and then you can go back in. Okay.
Pressure.
There's AR. Huh?
The diastolic is
Yeah, the diastolic is quite low.
See, the patient's going to some sort of hot block, so maybe a little bit of pacing will be
Maybe you
helpful.
have to use your pacemaker.
يلا جو كسر والله. جو.
It's the same. I think you need to rotate your valve a little bit counterclockwise to align it to the other curvature. Clockwise counter until you align it in the middle.
Go up, go back, go back, go back. It's the line.
Pressure is better.
No,
Faisal, your valve is biased.
okay, it's the line. Go.
Bender,
Yeah, I think here I will prefer to deploy the valve in the co-planar view. I know that maybe the cusp overlap is better in the self-expandable, but with this anatomy, to know exactly that you are in the outer curvature, I will deploy it in the co-planar view.
I agree.
Yeah, it's important to know that you're on the outer curvature from that view.
go to the co-planar view. Let's see.
I have a comment on the position of the valve. If the valve didn't orient it to the outer curvature, this means that there is some fibrosis here pushing the valve. So I think it's wise to pre-dilate first with mean diameter with the balloon -1, then go with the valve. I think it will take a better position.
Because there is very little, there is little calcium, predilation usually here is not, but you could have fibrosis without calcium.
Because
So
exactly we don't know the etiology. So I think this is mixed maybe.
So you're thinking if there is fibrosis, fibrotic
Go now,
typically
Faisal.
pushing the
Let's see.
valve for the other side.
But I think they did already a mechanical dilatation with the valve, so I think it to be.
That was
but I
dilated
think the
already.
issue here is the valve orientation. If they change it on the descending and then advancing the valve.
Don't cross too much, Faisal. Just only above the valve and start. Keep it in the, because pulling it will bring it to the short curvature. So while pushing, keep it up. Don't start from high.
Yeah, so it looks that this is better,
But
acceptable
go
on this
caudal
view.
to remove the parallax. Okay. This is again cusp overlap.
No, this
No, this is cusp overlap. Go back to the co-planar view.
Go plan. You want to remove it in the front? You want to remove it in the front? Okay. Yeah.
Okay.
Yalla, go.
don't push the wire. It's already high.
Yeah, the only thing is when you push the wire, the prosthesis will go higher. If you,
Yeah, he's
Yeah,
starting
push
higher
and
already,
push
so-
technique with the wire and the prosthesis.
Push, yeah. Okay.
Once you have annular contact, you might consider controlled pacing now.
If you start pacing now, it's better, Faisal.
It's coming high.
perhaps if they can show us a screen of the pressure at the same time. Thank you.
Okay, Sini. Yeah, pressure is fine. Sini, let's see.
Still deep.
Deep? That's overlap.
It's very deep.
What do you think, Abdullah?
Yeah, I think it needs to be recaptured and attempted for the third time.
I think
That's
it's
too
very
deep.
low.
Yeah.
Dr. Taib, is the aorta horizontal in this patient?
Yeah, the horizontal, I mean, look, the aorta is not very horizontal, but
Because
the wire position, I think, is not helping him at all.
Then maybe you need to start much higher.
Don't forget that the valve will cant after he deploys fully, so it will tilt towards the greater curvature.
Yes, the outer curvature.
So yeah, so
But you're right about the wire.
I think still the valve is biased to the inner curvature.
Yes.
That's why you are having abnormal deployment, Faisal. Rotate the valve to go to the outer curvature, please. Realign the valve and the wire. If you rotate, it will go. Rotate while pushing in and out. Transmit your rotation. Still, you have to go to the other side, near the big tail.
From the beginning, you noticed that the wire was in the middle because of severe stenosis.
It's too high.
No, it's going to be the same.
If he pulls the wire, it will go down a little bit.
Push the wire a little bit.
no, actually, pull the wire actually here.
No, it will
But
go
he's,
down.
I think he's in a good position, better position now.
Yeah.
I'm afraid of pushing the wire to come up. Looks. Yeah, I think maybe.
It's going to be the same. It's slow from the other side.
It looks the same.
Dived in more now.
So a little test now.
Still big.
Hamad Al-Khabi, what would you do in this case?
It's tough. This is the third recapture. So I think a few things I can do. Put another wire into the LV, back mile or tough wire, really, you can push and make a little bit. Come back, pull the prosthesis, little breathe, come back to the descending aorta, a half quarter, more rotation. Push the wire to help you to go to the greater curvature. You have to be perpendicular to the aortic valve, otherwise it will be really a lot of stored tension. So I will push the wire and I will start deploying not high, lowish, and pull back to rest on the greater curvature. I think this is the whole it's tough sometimes. I don't think I need to come out and pre-dilate. I don't think there is a lot of calcium, but probably another wire, another stiff wire.
Yeah.
Who would go for a balloon expandable valve in this case?
Definitely easier.
Don't worry. While going up above the valve, keep it up to stay in the greater curvature. Because staying in the greater curvature, not by pulling, it's by pushing.
By pushing the wire, you mean?
No, by pushing the valve.
The
because
device.
they go up to the ascending, then keep the wire at the apex and push the valve forward. Once the valve touch the greater curvature, start the balloon.
It's both. You will need to have the wire very deep in the LV to touch the outer curvature and you push over the sheath.
You're going to have the same issue because the valve is biased toward the lesser curvature. So it's going to be low from the other side.
Yeah, you're already low on the left side, on the left cusp side.
Yeah.
The left cusp is very low. And if you rely on correcting itself, it may dive deeper even.
Yeah, unpredictable.
I would agree with Dr. Bender's comment about try to implant it in the co-planar view.
Faisal, it's very low. I think you have to come out. You have to try to go to the outer curvature, even if you rewire again.
Just want to ask the panelists.
I will reach out. I will rewire.
How many times would you resheath this valve?
6 times?
7 times.
But time after 3 or 4 resheathing, it doesn't behave exactly the same way on opening and closing.
Yes.
There is a higher chance of unfolding every time this happen. And I think with the usage of the same wire, you wouldn't have a different result. Either you change the wire now, or you accept the results that you're going to get with this wire.
I would definitely come back out, check the wire position. I think the wire is playing the whole game here, the wire position.
Faisal, come out and move your wire. Let's see where is it exactly. Come out of the LV, please.
Yes, yes, I agree.
Faisal, show us your magic. You have 5 minutes.
I agree. The wire, the whole thing is the wire.
Come out, pull back the wire. Let's see where is it exactly. Okay, push the wire more. Let's see where does it go. Push the wire.
I think there is a mixed.
Okay, now the wire is on the outer curvature.
In Egypt, we do a lot of cases of rheumatic nature of severe aortic stenosis.
Okay, try to go now with the valve.
Like this scenario in some cases. So pre-dilatation is mandatory for this case. I think even with this wire, if we do a pre-dilatation, because when he injects, there is like thick leaflets pushing the valve towards the middle curvature of the aorta. So I think pre-dilatation will be helpful for this case.
So again, you're thinking fibrotic leaflets, just for the sake of the audience,
Yes.
because there's not
Keep
much.
the wire in the apex.
Yes.
Yeah.
Okay, now it's much better.
Keep the wire, don't pull.
Don't pull. Push it again. No, if you pull it, it's gonna go to the middle again.
Call planer maybe better.
It's better now.
نفس الموضوع حيكون شوي deep on the other side.
Faisal, it's the same thing. I think don't continue. It has to go to the other curvature. Otherwise, it won't work.
Yeah, because
Capture and rotate. The wire was okay first.
I think that's time.
He has one more.
Just for the audience, you see what happens when you're not on the outer curve, on the left side, it drops.
Try to rotate. Capture, try to rotate. It's not gonna work this way.
I think one thing that I might consider doing is pull the wire and then put in a Lunderquist. Maybe that will help you go into the greater curvature.
Yeah.
A little bit better.
It's a better position. Better position. That's better.
Well, he's relying on the canting afterwards. It's going to be unpredictable. هو حيعمل canting.
Yeah.
It's going to be unpredictable.
Yeah, of
Once
course.
you're risking it. It's deep. It's very deep. It's very deep.
It's at the apex. I think again, probably you have to align the valve to the outer curvature. Initially, it was fine.
I will pull the valve and I will rewire again.
Yes.
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 We agree.
And consider Dr. Atabi's suggestion of having another Lunderquist or something in the curvature as well.
Yeah.
Do you have a curved Lunderquist?
Yes.
So Faisal, while you are there, rotate clockwise, please. Let's see.
Clockwise.
Yeah, okay. Rotate counter now. Counterclockwise.
So
It has to go to the outer. Yes, more. Okay. Now pull back or push the wire.
I would pull.
Okay, test now.
Pull the wire a little bit.
Okay, this is much better. If you can deploy it like this, I think it will be good. But keep on the tension on the counterclockwise to keep it on the outer curvature. It's all right. It will dive. It's going to dive by itself.
It's going to dive. There's a lot of tension then when you release.
Test. Make sure you're not. Okay, you need to push a little bit or
pull
back
the
the
wire
wire.
a little bit, maybe.
Pull back the wire because you're in the sinus now. Test again. Pull back the wire.
If we're confident that it's going to fall on the outer curve, maybe yeah.
This valve is open. Even if you change the wire.
Yeah. Oof. Keeps diving.
Personally, I will consider changing the valve to balloon expandable. Who will change the valve?
I would try to take out the parallax. Dr. Faisal, can you take out the parallax first and then...
Faisal?
I think before changing the valve, you need to optimize the procedure. This is the time where you stop and say, I'm going to pre-dilate, I'm going to change the wire, but I won't jump to another platform before I do that. I think your suggestion about really trying to deploy high, the outer curvature will work if the two operators do it together. Because all the time when they try to do that, it turns to the inner curvature.
Okay, you want to change the wire?
Yes. Back up Maya.
Sure, Faisal, we thought it's going to be an easy case, like it's challenging now.
I will change the wire and recross again and we'll see that.
Yeah, I think we
دائما الإنسان يؤتمن مأمن.
So the maneuvering consists of pulling and pushing on the device, pulling and pushing on the wire, but what Dr. Hussain had him demonstrate nicely is that the clock and counter, you will see where it's going to direct, and the counter directed into the outer curve. So this was a smart move, and you need to kind of juggle. You need to keep it. Yeah, you need to keep it, exactly.
Wait. Okay.
أعتقد capture lithium perfuse please and probably change your wire.
I will.
Still, I will consider a balloon expandable. I think the patient life is more important. You already tried 6 times or 7 times.
The pressure is a bit...
If it does not work, then please change the valve, take a balloon expandable. You can realign it to the annulus and it's easier to deploy.
Why is the pressure low at this point? It shouldn't be.
And give levofed intra-aortic.
It's coming. It's 60 now.
What do you give? Normally I give neosynephrine, phenylephrine 100, 200. Yeah, it's coming up.
Yeah.
What you give?
Take out. We have
how many minutes we have? Organizers, how many minutes we have? Eight minutes? Okay.
Did you give something for the pressure? What did he receive so far? Yeah, pressure is a little bit better.
Yes, sir, you can keep this wire and go with a new wire.
Yeah. So give me the sheet and put another wire.
If it behaves the same, then I think the issue is in the aortic root anatomy, and then you have to consider changing the valve.
That is the first time happened to us like this.
Although by CT, it did not
By
look...
CT, it's not actually unfolded aorta at all.
No.
Yeah.
No.
Pressure is better now.
How much did you give as pressure support? What did you give?
Phenylephrine 200.
Okay.
100 mic, norepinephrine.
200 mic phenylephrine, neosynephrine 200.
I would check that wire position.
So what's your step now? You kept the wire in the ventricle. Are you going with the curved Lunderquist?
You can go with the big tail, a new big tail, and insert another wire. All the big tail that's there. No, that's from the other side. See, the wire now is aligned to the outer curvature, but once you pull, it goes to the middle.
Would anybody try to recross just to change the, just in case we're stuck behind something? Meaning now you have the pigtail, would anybody think after all of this to?
Faisal, pull back your big tail to the subaortic area. Pull back, please, slowly. Let's see, is it, yeah, pull back. This is a free catheter.
Yes, it is a free catheter.
Thank you.
Yeah, that's...
It's not entangled into anything.
Exactly.
So we have not.
What was that wire actually?
Safari.
That's Safari?
Yeah,
Was
that was a
That
Safari.
was Confida.
The first one was Confida?
Yes.
It was Confida, okay.
No, I think it's... Okay.
So I think we go with a stiff wire right now in the apex, to leave it in the apex, so we have an outer curvature of the wire.
What wire you will use now, Faisal?
We are using backup wire.
Backup wire.
That's
Back
very
up mine.
stiff. That's
It's
very
very stiff. What wire did you have that you pulled out now?
Confida.
Yes.
Confida, okay.
So why did you choose this new wire now?
More support. Fixing.
Whoa.
Yeah.
I would push the pigtail again.
Yeah,
Go back to the pigtail before you
Push the
lose it.
pigtail.
Push your pigtail back again. Back in.
Okay.
Shall we remove? Yeah. Is okay?
Show us the wire. Where is the wire now? It's behaving the same, Faisal.
Huh?
It's behaving the same. The wire is still in the middle. So you're going to have the same problem. It's not the wire issue, it's an anatomy issue.
Yeah, why not? I mean, just it's the least harmful of the other options. Just pre-dilate and see if that changed the wire bias.
Yeah. Give me. I'll tell you about one.
like 18 balloon or something.
And push your wire a little bit in, let's see.
ما في فايدة. Sheet again. Sheet.
So this wire has sharp hinges. Usually you have to be careful with it.
So yeah, the backup wire has a transition zone, so you would be careful not to push on it to perf, to avoid perf.
If the same behavior, we shall return back to computer rather than
Safari, what about Safari?
You know, balloon on this, and then you can change, since you are there. Faisal, I will keep up the backup balloon expandable ready in case he becomes unstable. Because this valve, I don't think you will be able to deploy it. And I think safety comes first. Always you have to have a backup plan. Make it ready in case something happens.
Abbas, backup balloon, Edward.
What size are you choosing?
26.
Yeah, 26.
26, yeah.
Yalla Abbas. بس لا يصير عباس ما هو بصدق يا فيصل. يلا, where's the balloon coming? Are you going to balloon?
But our concern about balloon, because the patient has moderate, mild to moderate aortic regurg.
Faisal, personally, I don't believe in ballooning. You already ballooned the valve 6 times mechanically, isn't it?
Yeah.
It was fully expanded the valve, so there's no fibrosis and there's no calcifications. The valve is fully open, by the way. So ballooning, I don't think it will realign your wire. It's the anatomy. You have to admit it's the aortic root anatomy what's causing this. And I think you should shift to the other valve and save your patient. I don't know if any audience or panelist, what do you think?
Push to the short curvature.
Abdurrahman, the valve is short from
I know, but
the outer curvature and deep from the inner.
The valve goes to the greater curvature. This is the time to start deploying, not to wait until you cross the valve, then you deploy.
Panelist, any comment?
Yeah, Dr. Abdurrahman, you might be more expert with the Medtronic than I am, but it's too much assuming or too much assumption that the valve will cant. It's quite very deep on the left side. Even when he deploys from high up, even if he's at zone 0, at the non-cusp, at the non-coronary cusp, it's still too much assumption that the valve will cant to compensate.
Predict, I agree. You don't predict what's going to happen when you release it.
When I say,
Faisal.
Is the CT that you reviewed for the same patient?
Yeah.
You're going to teach me something that I'm not seeing right now. Why
the wire
anatomy is not fitting with the valve.
Exactly, I agree.
There's no horizontal aorta. So it's not all about now thinking about what we need to do different.
I agree.
Pre-dilatation is one. I agree with the mechanical part, but with pre-dilatation there is the supraannular part at the leaflet level that we have not reached with the previous part.
Yeah.
So that is why I think pre-dilatation should be tried. The choice of wire is good, but I think manipulation is very important to achieve that horizontal part
yeah.
greater curvature for at least 2/3 of them.
أو حتى coaxial دكتور فيصل حتى لو يكون coaxial شوية.
And I agree with the balloon expandable if this didn't work.
Yep. Yeah.
Faisal, maybe Bashar, you have experience more than us with the valve, so maybe you can do it, but we can't. So you have to appreciate our limited skills in this.
I think also
and allow us to go for another valve.
It's a fibrotic valve. I think this is the other reason why it's slipping as well. Going for a balloon expandable here may be reasonable. You just go up and down and that's it. If this is failed, even with a stiffer wire.
So are you going now with the catheter or with the balloon?
لا Hussein, are you hearing me now?
Yes, yes.
Yes, actually, I would like to try. I would like to try again the pump with this wire. If failed, I directly go to balloon expandable cone.
Faisal, your valve has to lie on the outer curvature. If it does not, then it's not gonna work. Try the counter again and keep it there. Once you align it to the outer, do not pull back. Okay, start low. Once you capture, you can start pulling back, okay?
Okay.
But I think if it does not work, please consider shifting to balloon expander.
While we're waiting for this, I'm just going to drop a question or a thought challenge to the panelists. Since there is not much calcium, and we said that this is like there is not much constraint to the valve, who would think of going to a bigger valve to just make it more stabilized? I know 34 will be less of a stabilizer, but is that a mechanism here that the valve is dancing too much?
You know, I wouldn't, because it's maybe taking a bit more risk if we're in the same position again as we're deploying it. Because a bigger valve has a tendency to dive in
more, yes.
So you know, with this lack of control that we're seeing, I think you have a good point, but the counter of that is that it's a bit more risky, I think.
Yeah. With a bigger valve, you're going to have watermelon seeding.
Yeah.
So
into or most likely
rotate counter now, counterclockwise, until you bring it to the near the big tail. If you can't bring it there, then it's not going to work.
Which view are you?
Better.
You're doing it.
Okay. You know, Faisal, you have to push in and out to transmit your rotation.
We're not hearing you anymore.
And yes, we can't hear you. I believe this is cusp overlap again, yeah?
Yeah.
Yes.
Okay, we hear you now.
Okay, you are starting again?
Push little bit, just a little touching. Try this. Try this.
Who's with you from Medtronic?
أنا فاهم.
Pace now.
It's a very traumatic wire, Abdurrahman. No, it's deep from the other side. Look how deep it is from the other side.
This is a soft tip, huh? This is a soft tip, so there is not much pushability to it. It's better.
It's a little bit better than the last time.
Coblana. Let us take this. Coblana كده اللي فيه شوية. أيوه. Coblana كده اللي فيه. Remove the parallax, please. Remove parallax. In one line. Okay. It is in one line now.
Project.
It's good alignment. Good alignment. No, better.
No, it's still deep on there.
So I think sometimes we have to give up and go to the next plan. It's very deep, Faisal.
Deep on the left.
When Abbas ya Faisal?
I would really accept it in this. I mean, this is the second time we tried. You know, it looks good. You know, the price is basically pacemaker after all.
I would accept it as well. I think we just need to centralize the wire before final release.
Yeah, I think once we release it, it will take the shape of the outer curvature and it will be better. I think this is good.
Pull the wire, Faisal.
What if it dives, yeah, Bandar? How can you make sure to
pull the wire to centralize the cone and then...
I think we can release this valve while pacing, keeping push position. Maybe it will be a little bit slow, but it will take it for sure.
It's already low from the other side. It's very low.
No, this is good. This is good.
But it will be.
Who thinks that the valve is good?
Acceptable.
I would release this one.
Pace and release. At 160, pacing and release.
And who thinks that the valve is very low?
It will count. It will count. It will count towards the greater curvature, exactly.
Yeah, it will take a shape.
Yeah.
What do you say? What do you say?
I would just rapidly pace a little bit.
Listen. We will release the valve on this. What do you think?
Okay.
The audience thinks, yes, you should release the valve, but under pacing.
Faisal, before you release, control pacing and pull the wire to centralize the cone.
Hello.
It's gonna die.
Yeah, tented.
Pacemaker off. Pacemaker.
Stop pacing.
Stop. Pressure is okay.
catheter بس ما في AI. To diastolic is good.
I will take this wire out. Take it.
No.
شوية ممكن يكون نزل يلا اوكي.
Diastole is very good.
رجع اضغط فوق يا ربي.
Yeah, it's deep.
Well, I was saying the diastole is good, but then there is quite a bit of AR.
It's deep. The valve
So
is
this
deep.
is what we were talking about. When you release the valve, it will correct itself in the wrong way. It's going to dive in.
This
We
is
do both
significant.
dilatation.
Anyway,
Looks fine, huh?
I think you've done a great job. Thank you.
Okay.
It's too early to judge the AI because you just took a very stiff wire and the leaflet could be still lazy. So I would also advise the team to wait and just look at the orthogram and an aerial view. But again, very difficult anatomy. Back to the pre-dilatation, you could still constrain the valve. So
But Dr. Faisal, if you see the annulus is actually at node 6 تقريبا, it's deep.
It's deep. Now you want to assist the AI. Give it a bit of time before you judge the center, because there's also central AI.
We will remove this. We will put the 14 French.
يلا حط لنا بنانه. اعطينا بنانه يا عم.
Okay, Faisal, shukran. Please update us later on على الحالة. If you can give us an angio at the end of the day, please send it to us. We appreciate your presentation. It's a very challenging case. You've done very well, you and your team. Thank you for your effort. And have a good day. Well done.
Thank you very much. Hello. Thank you for allowing me another time to further explain to the things. I think we finalized that we found that there is regurg, and we followed the plan that we planned to do balloon post dilation. Yes. And I will one second.
This is the balloon, yeah. Go back.
Yeah. Yes. And we did balloon dilatation and the shape of the valve getting better. Here it's very more obvious. And here, after the balloon, there was very mild or trace regurg, and this is showing that the regurg is little bit milder. The accessibility to coronary, it was very easy, as you see. This is the RCA, and here the lift system, showing that there is nothing. And as you see here, the peripheral manta, we closed it successfully. There was no bleeding, nothing. And the patient returned to sinus rhythm. So I think it's acceptable result. We're expecting that the age of the patient is good. So everything is okay. Hopefully the things will be better. Thank you.
Thank you, Doctor. Good to hear things ended up in a good way at the end. It was a challenging case. Everyone were on their toes. Lots of comments coming from the room. So we thank you for Rahabat Sadrak being involving us in your experience in your center. And thank you for giving us the heads up and the update on your case. Amazing work from your team, showing all the precision and trying to do what is best at the end of the day for the patient. Thank you, Doctor. And hopefully we'll see you in another time, inshallah.
Thank you. Thank you for your support. And this is a very
We're
good
always here to
opportunity.
support. Yes. Thank you, Doctor.
Thank
A
you.
round of applause, please, for the team.
Bye.